All right, so welcome back to Ultrasound Grand Rounds again this week. It is 2026. It is cold outside. It is snowy. It is officially winter. And if you guys have been watching this channel recently, you may have noticed that the pace of video production has slowed down a little bit over the holidays, and that's because I was on an extended leave after we had our 6th child as a family. I took a couple months off over the holidays and spent some time meeting my new daughter and spending time with my other kids and helping my wife and just kind of easing that transition as we added a new family member to our household. But I'm back at work. I've been back for about a month now, and we're getting back into the rhythm of our ultrasound lecture series for this winter and this spring. So while I was gone, Sandy Werner had a conversation with Dr. Robert Owen about using TEE, or transesophageal echo, in the emergency department to help us resuscitate patients. So I'm pretty excited to bring that lecture to you guys today. I'm going to turn it over to Sandy and Dr. Owens. Here we go.
Thank you for joining us for Ultrasound Grand Rounds today. I'm Sandy Werner, and I'm stepping in for Dr. Tabbitt, who is off taking some well-deserved time off with a new family member. And today we have with us Dr. Robert Owen from our anesthesia department. He's an assistant professor at Case Western and does cardiac anesthesiology here. And he is going to talk with us about using TEE, resuscitative TEE. So I'll hand it over to you.
Perfect. Thank you very much, Sandy. So I'm a cardiac anesthesiologist here at Metro, which pretty much means I'm a general anesthesiologist who does the heart every now and then. But I have a great passion in TEE, not only in the cardiac ORs, but outside. So we're just going to kind of run through a quick intro about how you guys can use TEE in the resuscitative setting, in the emergency department, or in a critical care setting. So we'll understand the indications for its use, as well as touch a little bit on the evidence behind it, when we should not be using a TEE, both the relative and absolute contraindications, the complications that can happen with TEE use, and then there's 20 basic views of a standard TEE exam. We'll kind of go through some of those basic views, and I'll highlight the ones that I think are of the highest value to you in a critical care or emergency setting. And then we'll show some examples of pathologies on TEE. Yeah, would love to change that slide, but here we are. So when can we use TEE? So this is a statement by ASA and SCA. So those are my societies, American Society of Anesthesiology and Society of Cardiovascular Anesthesiology. And this is a portion that's specifically related to critical care patients. So TEE should be used when diagnostic information that is expected to alter management cannot be obtained through a transthoracic or other modalities. So when does that happen? I mean, we use transthoracic ultrasound, we use, CT scanners. We have a lot of different tools that we can use to get information. Well, we are a level 1 trauma center. People do come in with penetrating chest trauma. People may have bandages from recent cardiac surgery that precludes the ability to get a traditional transthoracic view. So this is a very similar set of guidelines. SCA and then ASE is the American Society of Echocardiography. And they say that evaluation of cardiac and aortic structure and function in situations where the finding will alter management and TEE is non-diagnostic, or TEE. Sorry, I think there's a mistype there. TTE is deferred because there's a high probability that it'll be non-diagnostic. So what are those kind of situations? If you have a suspicion for an aortic dissection, for instance, transthoracic echo for a far field structure such as the aorta usually is going to be non-diagnostic. Sometimes it can be, but TEE is going to provide you a better view of that ascending aorta. We all know that in order to clear the left atrial appendage prior to cardioversion, now sometimes people will use a CTPE, but generally speaking, the gold standard for clearing the left atrial appendage for a clot is going to be a transesophageal echocardiogram. Prosthetic heart valves, especially a mechanical valve where you have a huge amount of acoustic artifact when you put that probe on the chest, can make it very difficult to get a diagnostic view on a transthoracic echo. Vegetations and paravalvular abscess, again, the gold standard for diagnosis of endocarditis is going to be your TEE. And then there are limitations of TTE based off patient habitus, their conditions, wounds, dressings, knives in the chest, things like that. The other thing I do like to mention is that TEE can also be used for procedural guidance. For you guys, the most important ones are going to be, I will actually say, in addition to these, even just placing central lines. I use it all the time for that, but also an initiation of mechanical circulatory support. So an intra-aortic balloon pump, a Impella, or cannulation for ECMO. So there is this project called Resuscitative TEE. And the idea of it is using TEE in the ED and ICU to provide your diagnostic information. Support clinical decision and resuscitation of critically ill patients. So it can serve as an adjunct during ACLS to provide diagnostic information as well. This should be playing. I think sometimes I might have to do this where I exit out of the full screen. My understanding is that you guys are using TEE in this context quite a bit already. And what we have here is a heart that is very clearly in trouble. And we begin ACLS, right? Barely opening of the aortic valve from the native cardiac output. We start ACLS, we're giving chest compressions, and you can see the aortic valve opening with every compression. This is just one more way to know that, yeah, we're doing good CPR. Very good. So what is the evidence for using kind of this idea of resuscitative TEE? So this was a relatively, now it's getting, I guess more and more outdated. This was from 2022, 2023. It was a meta-analysis of critical care patients where TEE was used. So 108 different studies, 6,500 patients. And so obviously, right, such a big meta-analysis, you're going to have a lot of variance in your results. But the TEE was reported to change your diagnosis in half to 3/4 of patients. So think about it. If we're missing the diagnosis or going down a wrong path, and even let's take the low end, half of our patients, we're going to be causing a lot of harm and we're not going to be addressing the problems that are actually at hand. And then, sometimes maybe you didn't get the diagnosis, but you were managing it decently. Well, again, huge variance, so take it with a grain of salt. But TEE was reported to change the management in 1/3 to 4/5 of patients. So again, massive variance. But if we even take the low end of that, if we can use TEE to guide our treatment in 1/3 of the patients that we're taking care of, that's a huge amount, right? And then when we use TEE during cardiac arrest, you're able to identify the cause of the arrest in 1/4 to 1/3 of patients. And we're going to touch on a couple examples of that, one of which is very recent and close to my heart. Pardon the pun on that. So that's why we can use TEE, but there are absolutely times that we should not be using TEE. So there are times when putting the TEE may not be the right thing. But what I'm going to say is that different societies hedge on some of these guidelines and different authors hedge on some of these guidelines. I'm going to try and highlight a few things that are relatively consistent, right? So if the expected benefit outweighs the potential risk, go ahead, drop that echo probe in, right? That's what ASA and SCA say. Really, really generic. This is Dr. Ron Kahn. He's one of the experts in TEE. Lists some absolute contraindications. So stricture, diverticula, tumor, recent suture lines, interruption, and then some relative ones. Unexplained upper GI bleeding, varices, coagulopathy, hiatal hernia, right? So let's go, what do some other folks say? Clearly, this is someone who, speaks the King's English, but absolute contraindications are, again, stricture, fistula, trauma, esophagectomy. So as you can see, these are relatively consistent absolute contraindications. A perforated viscus, definitely something that we think about. But what are the relative ones? Diverticulum, a mass, maybe according to others, a mass might be an absolute contraindication. But this is just showing that, different authors will give you different risk factors. Ultimately, it's all going to come down to, is dropping a probe in this patient who may be risky to have a probe dropped in them likely to give you a life-saving answer? If that's the case, you should consider it unless you have, some of these absolute contraindications. Ones I do want to point out, atlantoaxial joint disease, often because there is going to be some manipulation of the head and neck while placing an echo probe. A thoracic aortic aneurysm, you can cause pressure on an unstable aneurysm that's abutting the esophagus. Let's see some other ones that I enjoy. Oropharyngeal pathology, if you have a huge honking, oropharyngeal cancer, maybe don't pass the probe right next to it and cause hemorrhage. Severe cervical arthritis, similar reason to atlantoaxial joint disease. And why do we list these, contraindications and whatnot? It's basically the number one thing is we're trying to avoid the most devastating complication of TEE placement, which is going to be an esophageal perforation. If you guys have ever seen someone with an esophageal perforation, they tend to develop mediastinitis, which can be extraordinarily deadly. So the overall complication rate of TEE, very low. And recall that this includes a lot of outpatient TEE. So, some huge numbers there. And awake patients tend to fight a little bit more. I think similar to me, most of the times that you guys are dropping probes in people, they either have no mental status or already intubated and sedated. Obviously, there's exceptions, but that would be my guess, is that most of the time you're doing this in someone who's not going to be fighting you too much. Other complications, the less serious one, right? Oropharyngeal trauma, laceration, dental injury, vocal cord injury. You can cause a Mallory-Weiss tear. There are a number of other complications, but the one that everyone is always worried about is going to be your esophageal perforation. The other complication that I think does not get talked about enough, and I think you guys have probably already seen when you get a great transthoracic picture, sometimes people's focus tends to wander towards the picture, right? And they lose sight of everything else that's happening with the patient. And this is something that happens in the operating room with my residents certainly quite a bit, because if you've had some TEE pictures, you know that it's even better than a TTE. It is beautiful to look at. It is something gorgeous, and it really does take your attention away. And this is something I've noticed particularly with residents. They'll focus here without realizing that while manipulating the probe, they detached the breathing circuit and the patient hasn't breathed in like 30 seconds. So I think distraction from patient care is another complication of TEE that doesn't get mentioned enough. So I did want to take that time to kind of talk about it. So why are we using TEE? It has some very unique skill sets, right? So omniplane is probably the most unique, and you can always tell on a test question a TTE versus a TEE because it should be showing you the omniplane angle for TEE. What does that mean? So that's the ability to rotate the ultrasound beam that's actually sent out from those piezoelectric crystals up to 180 degrees. Whenever I'm teaching this, I just have this habit of shooting out the ultrasound beam from this angle, 90 degrees for an omniplane. The ultrasound beam goes out like this, 180, right? So that's the idea of omniplane, and it allows you, without really moving the probe, to get multiple different images of multiple different structures. And you can, in fact, get two images at the same time of an orthogonal plane by using something called X-plane. It's a button that we have on the TEE. It allows you to show, let's say you're at 0 degrees omniplane, it shows you 0 and 90 at the same time. Excuse me. And then we have 3D imaging, right? So a very, unknown thing is that the actual purpose of the mitral valve, the reason the gods invented it, is for transesophageal echocardiography. All right. You create the best 3D pictures of the mitral valve with TEE, and that I will go to my grave convinced of that. So 3D imaging allows for this image reconstruction of cardiac structures, particularly valvular structures. I will say you always have to have a good 2D image to create a great 3D image, and there's always a balance between spatial and temporal resolution. You guys are very kind of adept with ultrasound physics, so I don't think I have to go into kind of the difference between spatial and temporal resolution, right? Here are no objections. I'll continue on. The unique movements that you see in TEE, right? So when you're talking about transthoracic, you're talking about rotation, you're talking about kind of rocking, you're talking about translocating. TEE is also going to have its own unique movements, right? So you advance the probe, you withdraw the probe. So changing where, from the esophagus to the stomach, the actual probe is. So I was just going to point out the piezoelectric crystals are generated from, the tip of the ultrasound probe in this kind of square. Sometimes it looks like a circle depending on the probe. So that's what you're thinking about withdrawing and advancing is where those piezoelectric crystals are. You can obviously rotate, so clock or counterclock the probe. You can flex the probe, so you can antiflex or retroflex. So that's bending the head of the probe either anteriorly or posteriorly. You do have a left-right flex. So the antiflexion retroflexion is generally the large wheel on a TEE probe, and the small wheel is going to be the left-right flexion. One thing I will always say is that you do want to be very careful about your left-right flexion while you're in the esophagus. As you can imagine, this is a little bit of a strain on the esophagus to have extremes of flexion in the left-right direction. For some reason, obviously you want to be careful about antiflexion and retroflexion, but that's generally going to be tolerated a lot better. And then we have that omniplane angle, like I mentioned before. So that just changes the angle that the ultrasound beams leave those piezoelectric crystals. So what are the basic TEE views? Like I said, there's 20 views that are considered, part of the basic TEE exam. I put a couple of stars here on the ones that I think are going to be the highest yield, and that also the Resuscitative TEE project believes are going to be the highest yield for you guys. A couple of abbreviations that you need to know. They basically, these first three refer to the level that you're at. So upper esophageal, mid-esophageal, transgastric, from highest to lowest, obviously, and then short axis versus long axis, particularly if you're looking at tubular structure like the aorta. Aorta and short axis here, you turn it 90 degrees, you're going to have a long axis. If you're looking at a valve, right, this is your mid-esophageal aortic valve and long axis. If you turn it 90 degrees, you get the mid-esophageal aortic valve and short axis. So those are kind of some basic concepts in acquiring these views. So you drop your probe in, you don't change your omniplane angle at all, and you see something thumping, hopefully, right? Generally, the view that you're going to get first is this mid-esophageal four-chamber view. This is one of the highest yield views because you get just kind of global cardiac function and filling. You can, often see some kind of pericardial disease on this. You can see the proportions of the RV and the LV. You can see the function of the RV and the LV. And of course, you can see atrioventricular valve function. And what I do want to impress upon you guys is that when you're in a resuscitative situation, all of your TEE should be qualitative analysis, right? When you do advanced perioperative TEE like me, I do have to do a great degree of quantitative analysis and quantifying the severity of different diseases. What you need to do is figure out why your patient is dead or unstable and fix it, right? So I'll probably emphasize this a few times. What you really want to focus on are these global qualitative analyses. So moving on, not the highest yield for you guys. Mitral, mid-esophageal mitral commissural view, omniplane angles generally at 60 degrees. This is special because it allows you to delineate some of the scallops of the mitral valve, so P1, A2, and P3. Sometimes you can get a good view of the left atrial appendage right here, although usually I'll say that's going to be better in the mid-esophageal two-chamber view, which is right here. So going from 60 to about 90 degrees, you get this mid-esophageal two-chamber view. I wouldn't necessarily discount this view because, again, you can get some global function of the LV, but instead of seeing kind of the lateral and septal walls, right now what you're seeing are the anterior and inferior, what a cardiologist will call the posterior walls of the LV. So whenever you're at about 90 degrees omniplane angle, anterior or superior structures are going to be on the right of your screen, and inferior structures are going to be on the left of your screen. So you do get some idea of mitral valve function. But like I said, knowing the anterior and inferior wall function is very important. You get to see the left atrial appendage the best right here. Also, this patient has a very obvious coronary sinus. Not that you would ever need to be looking at the coronary sinus, but it's pretty there. So I'd just point it out. Another one of the high yield views in that resuscitative TE project. So this is going to be the mid-esophageal long axis view. Usually 120, sometimes up to 140 degrees of an omniplane angle. You see the anteroseptal and inferolateral wall motion. You see very good mitral valve function. And you see the aortic valve function, right? So this is that view that they kind of had the probe parked in when they were doing CPR in that clip that I showed previously, because you see this aortic valve opening very well. And you can see the aortic root in the proximal ascending aorta. Sometimes you can even see the coronaries coming off here, which can be a very important thing if you're evaluating a type A dissection. If you see type A dissection and that dissection flap is occluding the coronaries, you need to get to the OR, 20 minutes ago. So moving on, mid-esophageal aortic valve long axis. This is very similar to the mid-esophageal long axis view. It's just we've focused in on that aortic valve, again, in long axis, right? So you're focusing on your LVOT, your sinus of Valsalva, your sinotubular junction, and your proximal ascending aorta. Again, usually around 120 degrees. Not a terribly high yield view, in my opinion, right? Going from a long axis view, you decrease 90 degrees, you're going to get a short axis view. So usually around 30 to 40 degrees, you'll get this mid-esophageal aortic valve in short axis. I don't know if this is the same in emergency medicine, in anesthesia. This view is almost always tested on our residents in training exams, and that's basically identifying the cusps of the aortic valve, the non-coronary, which is always right there next to the interatrial septum, left coronary, and right coronary. One thing I do probably should have mentioned earlier, if we go back all of these mid-esophageal views, right, starting at the four-chamber, what is the chamber that is closest to your echo probe if you're in the esophagus?
LA.
The LA. And that is something to help you kind of orient yourself if you're not sure where you are. If you're in the esophagus, the chamber that's closest to your probe, remember your probe is up here, is going to be your left atrium. That's why, sometimes patients with mitral stenosis present with dysphagia because they get huge left atrial enlargement and it actually pushes on their esophagus, right? So here in this commissural view, again, this is your left atrium in the two chamber. Left atrium in your mid-esophageal long axis, right? Left atrium in your aortic valve short axis. So carrying on, this is actually, I think, another one of the views that is a little bit underestimated by the resuscitative TE project. This is the mid-esophageal RV inflow-outflow view. So it's actually very similar to that aortic valve and short axis, a little bit higher omniplane angle and less focused on the aortic valve. But you usually see it pretty well here. What your focus is on this RV, right? So chamber closest to the probe, your left atrium, interatrial septum here, right atrium, tricuspid, your RV, your pulmonic valve. And you can really see free wall motion of your RV, which is very important. One of the pathologies that you have to be able to rule out in someone who is arresting, to me, is going to be a pulmonary embolism. And here you can see that kind of, the lack of movement of the RV free wall. You can see an RV that is blown out. I have multiple times seen clot in transit through the RV. So it is in my mind, a very high yield view, although it's not recognized by Resuscitative TE project as such. But what is mid-esophageal bicaval view. This is usually around 90 degrees. Again, left atrium is going to be closest to your probe. Since we're at 90 degrees, the head and anterior structures are going to be towards the right. So this is going to be your SVC. It's not popping in here, but you can sometimes see the right atrial appendage as well. This is very important for, yes, evaluating the intraatrial septum, finding out if there's PFO, ASD, something like that. But more importantly, this is going to be one of your best friends when you're doing some kind of procedural guidance. So if I'm doing a central line on a heart, I already have my echo probe in. My resident is working on the central line, right? Everyone says gold standard for ensuring that you're in a vein is going to be manometry. Personally, I push back on that, although on the test, that's going to be the answer. I push back on it because if a patient has rip roar and TR, that manometry could still look kind of pulsatile. So if I find their wire in the right atrium, I know they're in a venous system, right? So I use this for central line placement all of the time, but it can also be used for the placement of ECMO cannulation as well, usually obviously coming up from the IVC as opposed to the SVC. You can evaluate hardware that may already be in place, like a pacemaker lead or an ICD lead. By the way, if you are placing a central line, one of the things to always bear in mind is that your central line wire has that J loop to allow you to help to distinguish it from something like a pacemaker lead or something like that. Or at least that's what I'm going to say it's there for. And you can see some volume responsiveness from this view. So mid-esophageal ascending aorta in short axis, you see ascending aorta, main PA, right PA. Very rarely can you actually see the left PA because the left main bronchus, which again is full of air and ultrasound don't mix, obscures your view of the left PA. But you can see the right PA very well, SVC, ascending aorta. I've used this view to confirm a PA catheter placement. But also sometimes, like I said, you can see clot in transit in the pulmonary arterial system. Anytime you go from a short axis and you increase to about 90 degrees, you get a long axis. So this is your ascending aorta in long axis. In our previous view, the right pulmonary artery appeared in long axis here. You change it to 90 degrees and it'll appear in short axis. Not a high yield view, honestly. But you can sometimes evaluate like an aortic dissection here. All right. There are very few upper esophageal views, and frankly, I don't find them to be much useful unless you're concerned about aortic pathology, like a dissection. So 0 to 10 degrees upper esophageal aortic arch in long axis. You can sometimes see the innominate vein. And then upper esophageal aortic arch in short axis. So we go from 0 to 90 degrees. We go from long axis to short axis. You'll often see the pulmonic valve in this view and the main PA, but your goal is seeing this aortic arch in short axis. Again, sometimes you can see the innominate vein. Now we go down into the stomach. Whenever I'm doing an exam, I tend to start in the esophagus and then go to the stomach. So as we go into the stomach, you'll note that these views are labeled TG or transgastric. So transgastric basal short axis, sometimes called the fish mouth view, it looks like a fish mouth. It's a very good view of the submitral apparatus, and it's a basal view. You can get assessment of the LV wall motion in a basal view. But what's much higher yield is going to be your transgastric mid-papillary in short axis. So you get your anterolateral, posterior medial papillary muscles. You can see your RV. You can compare your RV to your LV size, and you see motion of your LV within all three coronary distributions, right? But the one thing I'll always say, one is that most people are used to doing a lot more TTE than TEE. And this looks exactly like your TTE peristernal short axis view, right? On your TTE, your probe is up here, meaning the wall closest to your probe is going to be your anterior wall. That's not the case here. Here, your probe is behind the heart. So your anterior wall is actually the farthest from it. So anterior, inferior / posterior, however you want to call it, septal, and lateral. And that is a question that trips up a lot of test takers and can trip you up in clinical practice if you just kind of forget what you're doing. Okay? This is always heavily tested in anesthesia boards, knowing the coronary distribution. But the other caveat to that is you're only evaluating the cardiac function at one slice of the dancing donut, right? So if you have basal hypokinesis, if you have apical ballooning, you're not seeing this. So I tend to combine this with that with that X-plane function, and allows you to see one view and then an orthogonal view. I combine it with a transgastric 2-chamber. This allows you to see the entirety of the inferior wall, although you usually lose some of the apex, and the entirety of the anterior wall. So now if there is a lesion causing some regional wall motion abnormality more distally, in the apex, I could see that here, but I can also identify kind of global function in that mid-pap view. So I love combining this view, which is a very high yield view, with this one using the X-plane function. Staying in the stomach, we have the transgastric long axis view, about 120 degrees. You can see your LVOT, your aortic valve, your aortic root. Transgastric RV inflow view, not one that I would consider terribly high yield for you guys, but it does emphasize the unique shape of the RV, that it's more of a kind of pyramid than just like a cone. Usually about 100 to 120 degrees. You can see tricuspid valve function, obviously. And then one of my favorite views is going to be the deep transgastric long axis view. If you have a patient with a mechanical aortic valve, this is going to be probably the best view to avoid acoustic dropout and see the most things that you can without it being obscured by that valve. This is also what allows you to align Doppler flow through the aortic valve. If you wanted to get, again, this is not being done to give you quantitative results. It should be qualitative. But if you can see, oh, wow, yeah, there's massive flow acceleration through that aortic valve, there's probably some kind of aortic stenosis that I didn't know about, right? So that's part of why I love this view. Usually 0 to 20 degrees, and it's the best view for kind of looking at those Doppler flows through the LVOT. Also want to evaluate the aorta within the stomach and thorax. So usually at 0 degrees, you can even sometimes see epigastric vessels coming off, mesenteric vessels, renal vessels. I usually do this after I've gotten my cardiac pictures in the transgastric view. I turn over, find the aorta, and kind of run it back cephalad. This is also a very good one. Once you're in the thorax, you can often see pleural effusions. You'll see a left pleural effusion a little bit better than a right, but you'll basically see lung tissue, and you can see layering of fluid in between the aorta and your lung tissue. So if you're concerned about, some pleural effusions, this is something that you can see. Anytime you go from short axis to long axis, you go from 0 to 90. Again, left-sided pleural effusions are pretty easily seen from this view. So I know that was a lot, right? But the ones that are probably going to be the highest yield for you that I want to make sure we touch on, right? So those mid-esophageal 4-chamber view. You stick the probe in. You don't have to change the omniplane angle. You see 4 chambers. You see the mitral and tricuspid valves. You see the pericardium. You can look for, tamponade effusion. You can see, rip-roar and MR from a ruptured pap muscle or something like that. You can see your LV and RV function. That's going to be one of the easiest to get and the quickest to get and give you a lot of information. You go from that view, you kind of focus in on your LVOT and go to about 120 to 140 degrees. You get this mid-esophageal long axis view where you can get kind of anteroseptal, infralateral LV wall motion. Again, you can see pericardial effusions. The quality of CPR, as we mentioned earlier, mitral and aortic valve dysfunction. Okay. And this is also showing you kind of the TTE equivalent of these views that you could get. Transgastric short axis, like I said, very similar to your parasternal short axis, just mirrored, right? So very good at seeing regional wall motion abnormalities amongst your coronary distribution. I personally like pairing it with the transgastric two-chamber wall explaning to see the entire length of the anterior and inferior LV walls. And then we have your mid-esophageal bicaval view. So very good for procedural guidance and volume responsiveness. So I know I ran through a ton of things. So I want to show you in what ways this can really be a life-saving tool, because, you know, just going through all of the different views can actually be very boring, and I apologize for that. But let's get it back to patients, right? So let me see. Yeah, it'll play. Okay, cool. So this is a woman in her 60s, didn't really see doctors, who came in following a cut on her toe. And this cut got infected and it wasn't getting better. Well, she didn't see doctors. Turns out her A1C was 14, right? And she also came in DKA. It was managed. She got a guillotine amputation, unfortunately, 5 days before I met her. She was coming to the operating room for a formalization of her guillotine amputation with vascular surgery. So she went to sleep okay, intubated her. My resident let me intubate, which was very kind of him. And then about 20 minutes later, my resident gives me a call. Hey, they haven't made incision yet, but our end-tidal CO2 just went from like 35 to 15 all of a sudden. That should always be a warning flag to you guys. Walk into the room, cuffs going off, you know, not reading in pressure, but there is a pulse on the pulse ox. Have my resident toss in an A line real quick. We lose the pulse on the pulse ox, and there's no pulse ox on, or there's no pulse on the A line that he got in. So we start CPR. We get ROSC relatively quickly, and I drop an echo probe in. Drops the probe in, mid-esophageal 4-chamber view. Does anyone see anything wrong? Anything wrong about how big the RV is, how small the LV is, the motion of the interventricular septum? You can see the interatrial septum is bowing over towards the left. So our right-sided pressures are clearly increased. Let's go through a few more views. All right, so I've now gone into the stomach. And again, I'm still at 0 degrees. And I've taken one of the common views that, you know, we went through and kind of turned over to focus on that right side of the heart. But this is your dancing donut over here. What do you guys think about it? Full or empty?
It looks pretty empty or compressed.
It is very empty and compressed, right? And everything is squeezing, although that septum is moving in a strange way. It's moving over towards the LV, so the right side of the screen, during systole, which is not exactly normal. And the size of our RV is much bigger than our LV. So again, I have some concerns that our right-sided pressures are increased. All right. Anyone remember what this view is? This is going to be your mid-esophageal RV inflow outflow. Again, chamber closest to the probe, your LA, interatrial septum here, RA over here, tricuspid valve, pulmonic valve, aortic valve kind of in a short axis, and this is your RV. What do you guys think of the movement of that RV free wall?
Not doing much.
Not doing much. Pretty piss poor. Pretty piss poor. Right? But there's a lot of reasons your RV could go bad. This is the one that was very helpful to us. So this is going to be your mid-esophageal ascending aorta in short axis. This is your ascending aorta towards the right of the screen, your SVC, and your right pulmonary artery in long axis. Someone can tell me why this patient has attempted death, right?
Looks like there's a clot.
There is. There is occlusive thrombus in that right pulmonary artery, right? And this fits very much with what we've seen in the last few images where our RV is blown out, our RV is struggling, our right-sided pressures are increased, and our LV is severely underfilled. So at this point, I was quite certain that this is an acute PE. I was able to call our interventional radiology team, had to do a lot more CPR and give a lot more epi, but got the patient to our hybrid OR suite. This is just another view. I kind of went to that right pulmonary artery and put it more into a short axis. And I mean, it's just huge amount of thrombus there, right? We were able to get an Inari catheter up the patient, and this is what we ended up sucking out. So again, you're not able to see the left pulmonary artery as well on TEE because the left main bronchus obscures it. But I was seeing all this clot within the right pulmonary artery. Red stuff is generally going to be your acute PE. White stuff is going to be some chronic. So she had a degree of chronic PE going on, which I didn't show one of those images. But after we had aspirated a lot of this clot, I was still able to see kind of, it almost looked like aortic atherosclerosis, but within the right pulmonary artery, where you just see stuff stuck up against the arterial wall. So she had some chronic PEs, but she clearly had a massive acute saddle pulmonary embolism that should have killed her. She actually is now extubated and completely neurologically intact. So this should impress upon you that when you don't know what's going on, you can really learn a lot when you drop that echo probe in, and it drastically alters your management, right? Without that echo probe, we can't make the diagnosis of PE with enough certainty to get the IR folks in there and aspirate all that clot out. Now we have a couple different pathologies. Obviously, we all know tamponade is a clinical diagnosis, as we're told over and over again, but someone want to just give a stab at what the view is here. Dropped our echo probe in, our omniplane angle is at 0.
It looks like your 4-chamber view, but
it looks like it should be a 4-chamber view, but there's a lot of extra stuff here, right?
Yeah.
Our RV is completely collapsed. Our RA is collapsing. We have collapse of our right-sided structures in systole and in diastole, and we can all see why. We have this very large pericardial effusion. This is something that I encounter sometimes with patients going to the electrophysiology lab who are getting, a pacemaker lead, particularly if they're getting an atrial lead. The atrium is pretty thin-walled, it can tear, and now they get cardiac tamponade. Right. So tossing that probe in, you can help see this. You can say, all right, you need to drain this tamponade. We need to, either do it percutaneously or do a window. All right. Next one. I think this one has music. I apologize. There we go. So again, this is similar to what we saw earlier, where we're doing CPR on a patient and then they hold compressions and you can see the fibrillation of the heart, right? We're clearly in VFib. This is, again, a mid-esophageal 4-chamber view. We've now shocked the patient, and we've resumed a sinus rhythm. So this is kind of using the TEE during a code situation. I will say, I think TEE is going to be most useful and most diagnostic for a PEA arrest, but it can certainly show you, yes, I'm confirming what I'm seeing on my EKG. This is a VFib arrest. But it's hard to get a reason for the VFib just from a TEE, generally speaking. TEE is going to be exceptionally helpful in narrowing your diagnosis or even confirming it when you have a PEA arrest. All right, I talked about this one earlier. far field structures like the aorta are not adequately evaluated on transthoracic echo. So you can see this aortic dissection here on the right side of the screen. It's probably occluding that right coronary ostium, which is going to be right there, and most likely the left. So this is going to be someone who is going to be struggling very soon. And this is the RV down here, and I can see that it's already a little bit big and not really beaten too great. So I think there's some RCA ischemia going on. And this is just a normal view for comparison. Again, aortic dissection. You do always have to try and I often have to try and figure out the true and false lumen, which can be difficult. But for you guys, you see a dissection, you call a surgeon. I mentioned this earlier when we're looking at the descending aorta and short axis, you can see a pleural effusion, particularly on the left side. I'm just trying to see if I can make it bigger, but you can see this is lung tissue here. You guys have seen enough ultrasound of lung to know that that's it. And then you have this layering of pleural effusion. And then, of course, wall motion abnormalities when you're concerned about coronary ischemia. All right, so if normal is over here on the left, this is very clearly abnormal, and the wall closest to the probe appears hypokinetic, if not frankly akinetic. I ran through a lot of images, I talked a lot, I did a lot of pictures, right? But how do I want to leave you guys? So TE, it's a very reasonable thing for you to do in an emergency setting when you have an unstable patient and you need to figure out why, and transthoracic echo or other imaging is unlikely to give you the diagnosis that you need, right? Can also be useful for procedural guidance, as I mentioned, but primarily, and of course in cardiac arrest, but primarily we need to get some form of diagnosis, right? So that we can alter our management. There are problems with putting in TEE probes, right? The most devastating complication that we worry about is going to be your esophageal perforation, right? And there are risk factors and contraindications to putting that probe in. So just be aware of those before you drop a probe. There's those 20 basic views, but there's a couple that are going to be the highest yield for you guys, right? So transgastric short axis mid-papillary view. So knowing those coronary distribution and remembering to not get caught up that it mirrors the TTE peristernal short axis. Mid-esophageal four-chamber, you saw a lot of examples of how that can give you a very quick diagnosis. Mid-esophageal long axis view for mitral and aortic valve pathologies, aortic root pathologies, opening of the aortic valve. And then the other one is going to be the mid-esophageal two-chamber view, which is very helpful for procedural guidance as well as volume responsiveness.
All right. So thank you, and hope you guys enjoyed that one. Thank you to Dr. Robert Owen for that wonderful presentation, and for Dr. Werner for covering while he was gone. If you enjoyed this video, hit that subscribe button, that notification bell, so you can know every time we publish new videos, and check out one of these other videos in the end card. Until next time, we'll see you guys. Have a good day. Bye.